Right now, go to the nearest mirror. Take this with you if you need to. Stand directly in front of it in the best light you have, natural light from a window, your bathroom light, your phone flashlight held steady at eye level, whatever gives you the clearest, most honest view of your own face. Now look at your eyes. Not the way you look at your eyes every morning when you are checking your appearance, deciding whether you look tired, assessing whether the concealer is adequate. Look the way you have never looked before, deliberately, systematically, with the specific intention of reading what is actually there rather than managing how it appears. Start with the whites, the sclera, the white area surrounding the iris on all sides. Look at the color, look at the texture. Look at whether there are vessels visible that seem more prominent than they should be, or a yellowish tint you have been explaining as lighting, or small yellowish deposits in the corner near the nose that you have been calling sleep crust that does not quite wash away completely. Now look at the skin around the eye, the upper lid, the lower lid, the crease of the upper eyelid, and the tissue directly beneath the lower lash line. Is there puffiness that is present specifically in the morning and takes time to resolve? Are there small, yellowish, slightly raised plaques, flat or barely elevated, cream to yellow in color, sitting in the skin of the eyelid itself, particularly near the inner corner? Now look at the iris, the colored part. Look at the outer edge of the iris, where it meets the white. Is there a pale arc, a grayish-white ring running along the upper edge of the iris, like a partial halo sitting above the colored portion of your eye? Most people over 60 have never looked at their eyes this carefully. And most people over 60 have no idea that what they are looking at right now, in under 60 seconds, with no equipment, no laboratory, no appointment, is one of the most complete windows into liver function available anywhere on the body surface. Your eyes have been showing you the state of your liver for years. Not one sign, 5 signs. 5 distinct, specific, separately mechanism signals that the liver sends through the eyes when its function is under strain. Signals that are present simultaneously in some people, present 1 or 2 at a time in others, that arrive gradually and are dismissed as aging, as tiredness, as skin changes, as eye changes, as the normal accumulation of years on a face that has lived them. None of them are normal aging. All of them are liver. I am going to show you all 5. I am going to explain the exact mechanism behind each one, what is happening inside the liver that produces each specific visible change in and around the eye. And I am going to give you the morning protocol that addresses the liver mechanisms driving all 5 signs simultaneously, starting tomorrow. Before the mirror shows you something it is too late to reverse. Stay through all 5 signs. Because sign number 3 is the one that is present in the majority of people over 60 with a liver condition that affects cholesterol metabolism in a way that no standard lipid panel fully captures, a condition that produces a visible mark on the eye that most people have been told is benign and cosmetic, and that is neither. Subscribe to Dr. Huang right now. This channel exists to teach you to read what your body has been writing on its own surface for years without translation. Hit subscribe and let us continue. You have been looking at this face in the mirror every morning of your adult life. You have watched it change through decades, through seasons, through the specific accumulations of a life lived in full. You know this face better than any other surface in the world. You know what it looks like rested and what it looks like exhausted, what it looks like after a good week, and what it looks like after a difficult one. And at some point, some morning in the last several years, you noticed something in the mirror that was different. Something you could not quite name but could clearly see, a quality to the eyes that was not simply tired, a color in the whites that was not simply the blue-white of youth having faded, a deposit near the inner corner of the eye that appeared one season and did not leave the following spring. You explained it the same way everyone explains these things. Age, fatigue, skin changes. The eyes just look different now. Everyone's eyes look different after 60. This is simply what that looks like. The explanation was available. It was comfortable. And it meant you did not have to ask the question the observation was actually requesting. What is producing these changes? Not age, not fatigue, not the simple passage of time. A specific organ working at reduced efficiency, expressing that reduced efficiency through the only tissue that sits close enough to the body's surface to make its internal state externally visible. The liver. Here is what makes the eye the liver's primary external communication channel, and why this connection is not metaphor but mechanism. The liver is the central metabolic processing organ of the body. Every substance absorbed from the gut, Every nutrient, every toxin, every medication, every metabolic byproduct passes through the liver before entering general circulation. The liver processes fats, metabolizes drugs, produces bile, synthesizes proteins, detoxifies compounds, regulates glucose, manages cholesterol, and produces the clotting factors without which a single cut would not stop bleeding. When the liver's capacity to perform these functions declines through the age-related hepatic blood flow reduction and enzyme decline I described in previous videos, through the fatty liver accumulation that affects a significant proportion of people over 60, through the chronic low-grade inflammation of inflammasome that progressively impairs hepatic enzyme expression, the compounds that the liver is supposed to process begin to accumulate. And because the eye sits at the end of a circulatory pathway that receives everything the liver has processed and everything it has failed to process, because the delicate tissues around and within the eye are metabolically vulnerable to exactly the compounds the liver manages, the eye becomes the site where liver dysfunction expresses itself most visibly, most consistently, and most early. The eye does not lie about the liver. It never has. It simply waits to be read. Before I show you the 5 signs, I need to be direct about what requires immediate clinical attention. If the yellowing of your eye whites appeared suddenly, over days rather than weeks, and is accompanied by dark urine, pale stools, significant abdominal pain in the right upper quadrant, fever, or dramatic fatigue that appeared at the same time, seek evaluation today. Sudden scleral icterus can indicate acute liver injury, bile duct obstruction, or hemolytic crisis, all of which require urgent management. If you have a known history of hepatitis, cirrhosis, or any diagnosed liver condition, and you are noticing new or worsening eye changes, report this to your hepatologist rather than applying a home protocol. If the yellowish deposits on your eyelids appeared rapidly, over weeks rather than months or years, and are growing visibly, clinical evaluation for the underlying lipid disorder should precede any home intervention. If any of the eye signs I am about to describe are accompanied by significant unintentional weight loss, persistent right upper abdominal discomfort, or visible abdominal swelling, those combined signs need clinical investigation this week. If what you have are gradual, long-standing, stable eye changes that have been building over months to years without acute crisis, then what I am about to show you is the systematic reading your mirror has been offering every morning without a translator. Now let me show you the 5 signs. The first sign, the yellowish tint to the whites of the eyes. I have described this in detail in the yellow eyes video, the bilirubin mechanism, the conjugation enzyme decline, the enterohepatic recirculation problem, the morning fructose connection. I will not repeat the full mechanism here because it exists in its own dedicated video for anyone who wants the complete explanation. What I want to add here, specifically in the context of seeing this sign alongside the other 4, is the grading system that tells you how advanced the bilirubin accumulation is and what the presence of this sign in combination with others means for the urgency of the intervention. Hold your phone flashlight at a 45-degree angle to your eye in a dark room. The direct illumination in a darker environment is the most sensitive way to detect early scleral icterus. The slight yellowish tint that overhead bathroom lighting normalizes by washing it into the ambient light of the room. Grade 1 is a subtle warmth. The white is not pure white, has a cream or ivory quality, detectable in good direct light but easily dismissed in ambient light. This is the window where dietary intervention has the most impact. Grade 2 is a clearly visible yellowish tint that is evident in normal light that other people may have commented on that shows clearly in photographs. This is the window where dietary intervention is still important, but where clinical assessment of bilirubin fractionation is simultaneously warranted. Grade 3 is unmistakable yellowing visible to any observer. This requires clinical evaluation regardless of any home protocol. If what you see in the mirror is grade 1, the subtle warmth, the not quite white that you have been explaining as lighting, the protocol I will give you is most powerful here in this window before grade 2 arrives. The second sign, xanthelasma, the yellowish plaques in the eyelid skin. Look at the skin of your upper and lower eyelids, specifically near the inner corner of the eye. Look for yellowish, flat, or slightly raised deposits. They may be small, the size of a grain of rice, or larger, sometimes merging into irregular patches. They may be on both upper lids, both lower lids, or any combination of the 4 eyelid surfaces near the inner corner. These deposits are called xanthelasma, from the Greek for yellow plate, and they are composed of lipid-laden macrophages, immune cells that have engulfed cholesterol and fat deposits and accumulated in the superficial skin of the eyelid. The standard explanation most people receive when they ask about xanthelasma is that it is associated with elevated cholesterol and is otherwise harmless. A cosmetic finding that can be removed by a dermatologist if bothersome, but that requires no other action. Here is what that explanation consistently fails to include. Xanthelasma appears when the liver is not processing and excreting cholesterol and its metabolic byproducts efficiently. Cholesterol is synthesized in the liver, packaged into lipoprotein particles, circulated through the bloodstream, and when the cycle is complete, returned to the liver for reprocessing and excretion through bile. When this cycle is disrupted, when hepatic processing of lipid metabolites is impaired by the same enzyme decline and reduced blood flow that drives every other sign of liver dysfunction we are discussing, cholesterol and modified lipid compounds accumulate in circulation and begin depositing in peripheral tissue. The eyelid skin has a particular vulnerability to this deposition. Its tissue is extremely thin, loosely attached, and richly supplied by vessels whose walls are permeable to lipid particles that accumulate in the tissue rather than passing through it. Xanthelasma is not a cholesterol problem that happens to express itself in the eyelid. It is a liver processing problem that expresses itself in the eyelid because the eyelid is among the most vulnerable tissues to the circulating lipid burden that impaired hepatic clearance produces. Multiple studies have confirmed that xanthelasma is associated with elevated cardiovascular event risk, independent of measured cholesterol levels. People with xanthelasma and normal total cholesterol have significantly higher cardiovascular event rates than people with similar cholesterol levels and no xanthelasma. Because the xanthelasma is reporting the hepatic lipid processing impairment that drives atherogenic lipid accumulation in vessel walls, the same process I described in Frank's sign, and this impairment exists independently of the total cholesterol number that standard lipid panels measure. If you have xanthelasma, even small deposits, even deposits you have been told are benign, your eyelid is telling you something about your liver's lipid processing capacity and your cardiovascular risk that your last lipid panel did not capture. The third sign, arcus senilis, the gray-white ring around the iris. Look carefully at the outer edge of your iris, where the colored portion of your eye meets the white. Is there a pale arc? A grayish-white, slightly hazy ring running along the upper portion of the iris, sometimes extending to a complete ring around the entire iris perimeter? This is arcus senilis, a Latin term meaning old arc, and its presence in people over 60 is so common that it has been categorized in medical teaching as a normal aging finding, requiring no investigation and generating no clinical concern. This categorization is incomplete in a way that has been allowing a significant metabolic signal to be normalized away in the very demographic where it most needs to be recognized. Arcus senilis is composed of lipid deposits, cholesterol and phospholipids that have infiltrated the peripheral cornea, the transparent dome covering the iris. The cornea is normally avascular. It has no blood vessels of its own, receiving its nutrients through diffusion from the aqueous humor inside the eye and from the limbal vessels at its very edge. It is precisely this avascular, diffusion-dependent nutrition that makes the peripheral cornea a lipid deposition site. Lipids that cannot be cleared through circulation accumulate at the diffusion boundary of the corneal periphery. The lipids depositing in arcus senilis come from the same circulating lipid burden that produces xanthelasma in the eyelid, and that the liver is not processing efficiently enough to prevent from accumulating in peripheral tissue. Here is the critical distinction between arcus senilis as normal aging and arcus senilis as a metabolic signal. In people over 70, arcus senilis is common enough to lack strong predictive specificity for individual risk assessment. In people between 55 and 70, arcus senilis, particularly a complete ring rather than a partial arc, particularly when present alongside one or more of the other signs in this video, is associated with significantly elevated risk of the lipid dysmetabolism that connects liver function impairment to cardiovascular disease. And here is what makes it specifically a liver sign rather than simply a cholesterol sign. People with xanthelasma and arcus senilis simultaneously, the combination of eyelid lipid deposits and corneal lipid deposits, have a hepatic lipid processing profile that goes beyond simple LDL elevation. They tend to show elevated levels of lipid compounds that the liver fails to process when its enzyme and bile acid activity is impaired, compounds including remnant lipoproteins, oxidized LDL, and IDL particles that the liver is supposed to convert to LDL and recirculate, but is instead allowing to accumulate and deposit in peripheral tissue. If you have both xanthelasma and arcus senilis, both sign 2 and sign 3, your eyelid and your cornea are reporting the same hepatic lipid clearance impairment from 2 different tissue locations simultaneously. The liver connection is not coincidental, it is bilateral. The 4th sign, prominent or reddened vessels in the conjunctiva, the spider veins of the eye. Look at the white area of your eye again, but this time look not at the color of the white itself, but at the vessels running through it. Tiny red lines like fine cracks in porcelain, visible particularly toward the outer corners and the lower portion of the sclera. A small number of superficial vessels visible in the sclera is entirely normal. The eye requires its own blood supply, and those vessels are visible in everyone. What is not normal is increased prominence, increased redness, and irregular or congested pattern that is present consistently rather than only when the eye is irritated, that is worse in the morning and does not resolve through the day, and that has been developing gradually over months rather than appearing acutely with an eye infection or allergen exposure. Prominent congested scleral vessels reflect elevated portal venous pressure, the pressure in the venous system that drains the gut and delivers blood to the liver. When the liver's internal architecture is disrupted by fatty infiltration, by fibrotic changes that begin long before clinical cirrhosis, by the congestion that develops when hepatic blood flow is impaired, the pressure in the portal venous system rises. This elevated pressure transmits backward through the venous drainage of the eye, producing the congested, prominent vessel pattern visible in the sclera. This is not a minor sign. Portal hypertension, even in its early subclinical form, is one of the most specific indicators of hepatic parenchymal change that examination can provide. And while the scleral vessel prominence that early portal hypertension produces is subtle compared to the dramatic esophageal varices and ascites of advanced cirrhosis, it is present earlier, it is visible without equipment, and it is available every morning in the mirror to anyone who knows to look for it. If you have prominent, consistently congested scleral vessels that are not explained by recent eye irritation, screen exposure, or allergy season GI, combined with any of the other 4 signs in this video, this combination warrants a liver function panel that goes beyond the standard 2-enzyme screening included in a routine annual physical. The 5th sign, periorbital puffiness, the specific quality of morning swelling around the eyes that does not resolve with coffee and waking up. I described the kidney connection to morning periorbital puffiness in the kidney video, the albumin loss through the damaged filtration barrier that reduces osmotic pressure in the blood vessels and allows fluid to leak into the periorbital tissue. That mechanism is real and important. But the periorbital puffiness that is specifically liver-mediated has a different quality and a different timing that distinguishes it from the kidney version. And understanding the distinction determines which organ to direct the primary attention toward. Liver-mediated periorbital puffiness is connected to albumin production, not albumin loss through the kidney, but albumin synthesis failure in the liver. Albumin, the primary protein that holds water inside blood vessels through osmotic pressure, is produced exclusively in the liver. The liver synthesizes approximately 12 grams of albumin every single day to maintain the blood albumin level that keeps fluid inside vessels rather than leaking into surrounding tissue. When the liver's synthetic capacity declines through the hepatocyte loss and functional impairment that accompanies progressive liver dysfunction, albumin production falls. Blood albumin falls. Osmotic pressure in the vessels falls. Fluid leaks into the periorbital tissue and accumulates overnight. The distinction from kidney-mediated puffiness is this. Kidney-mediated puffiness is worst in the very first minutes of waking and clears relatively quickly within 30 to 60 minutes as upright posture and movement redistribute the fluid through the lymphatic system. It responds to improved hydration and kidney support. Liver-mediated puffiness tends to be more persistent, present not just in the first 30 minutes, but through much of the morning, sometimes into the early afternoon. It responds less readily to simple upright posture because the underlying albumin deficit means that the fluid that drained overnight from the periorbital tissue is simply replaced again as more fluid leaks from vessels whose osmotic pressure is insufficient to retain it. If your morning eye puffiness has been gradually worsening over months to years, responds poorly to cold compresses and upright posture, and is accompanied by any of the other 4 signs in this video, the primary mechanism is hepatic albumin production insufficiency, not renal albumin loss, and the intervention needs to be directed at liver synthetic function rather than kidney filtration support. These 2 mechanisms can coexist. The same person can have both reduced liver albumin synthesis and reduced kidney albumin retention simultaneously, with both organs contributing to the periorbital puffiness that greets them every morning. But the pattern I have just described, persistent puffiness that does not clear through the morning alongside the other liver signs visible in the mirror, points to the liver as the primary driver. Let me tell you about someone I will call Matilda, 67 years old, former pharmacist, a woman whose entire professional life had been built around understanding what substances do to the human body. Reading mechanisms, predicting interactions, translating molecular biology into the language of patient care for 35 years. She came to me not because she was worried, she came because she was curious. She had been systematically examining her own face in the mirror for several years, not from vanity, she was careful to say, but from the same professional habit of close observation that she had applied to medication profiles and patient charts throughout her career. She had been keeping a photographic record of her eyes, taken monthly in consistent lighting, because she had noticed a pattern of gradual change, and her professional instinct was to document what was changing before she tried to understand why. She brought the photographs, 18 months of them, 12 images dated and organized. The early photographs showed eyes that were unremarkable. Normal white sclera, no visible deposits, minimal vessel prominence, mild periorbital puffiness in the morning images that resolved quickly. The later photographs told a different story, one that had developed so gradually across 18 months that no single image showed a dramatic change. But the comparison between the earliest and most recent was unmistakable. The scleral color had shifted from white toward a warm cream in natural light. Small yellowish deposits had appeared on both upper eyelids near the inner corner, barely visible in the early photographs, clearly present and slightly larger in the most recent. A partial grayish arc had appeared along the upper edge of both irises. The periorbital puffiness in the morning photographs had increased in prominence and appeared to persist longer. She had one question. She said, "I know what I am looking at. I need to know which of my liver enzymes to check and which ones my doctor will not think to order." She was not frightened. She was the most prepared patient I had seen in years. We ran the comprehensive panel she had correctly anticipated: standard liver enzymes, bilirubin fractionation, GGT, and alkaline phosphatase specifically, fasting lipid panel with direct LDL measurement, a polypoprotein B, serum albumin, and a hepatic ultrasound with specific attention to hepatic echogenicity, the pattern of sound reflection that distinguishes normal liver tissue from fatty infiltrated tissue. Her ALT and AST, the standard liver enzymes, were within normal range. Her doctor would have looked at those 2 numbers and said her liver was fine. Her GGT was elevated, GGT being the liver enzyme most sensitive to alcohol and fatty liver change, most specific for early hepatic dysfunction, and least routinely measured because it is not included in the standard 2-enzyme liver screen that most annual panels contain. Her fasting triglycerides were elevated. Her apolipoprotein B, the protein component of every atherogenic lipoprotein particle, a more direct measure of atherogenic particle number than LDL cholesterol, was significantly elevated despite a LDL that would have generated no clinical concern. Her serum albumin was at the lower end of the normal range, not below the laboratory's reference range, but at a level that in the context of her symptoms and examination findings suggested reduced synthetic capacity rather than adequate function. Her hepatic ultrasound showed moderate hepatic steatosis, the fatty liver accumulation that affects an estimated 25% of adults globally and a significantly higher proportion of people over 60 that generates no symptoms, produces no pain, causes no obvious functional decline in its early stages. And that is not included in any standard annual screening protocol, despite being one of the most significant drivers of progressive liver dysfunction and cardiovascular risk in the aging adult population. The standard screening had told her nothing was wrong. Her mirror had been telling her something was changing for 18 months. Her mirror was correct. She implemented the protocol I am about to describe alongside referral to a hepatologist for monitoring of the fatty liver finding. At 16 weeks, her GGT had fallen into the normal range. Her triglycerides had reduced significantly. Her morning periorbital puffiness had reduced, both the duration and the prominence. Her most recent eyelid photographs showed the xanthelasma deposits appearing slightly less prominent, which she had not expected and which I explained reflected improved hepatic lipid clearance, reducing the circulating lipid burden that had been depositing in the eyelid tissue. She sent me the most recent photograph alongside the earliest one in her collection. She said, "The liver talks to the eyes. I should have known this earlier. I was trained to read the body. Nobody trained me to read the mirror. Here is the protocol. Every element targets the specific liver mechanisms driving all 5 signs simultaneously. Bilirubin conjugation for sign 1, hepatic lipid processing for signs 2 and 3, portal venous pressure for sign 4, and albumin synthetic capacity for sign 5. The morning liver activation sequence. This must happen before any food, before coffee, before anything that places a processing demand on a liver that has been in its overnight state for 8 hours and needs specific signals to activate its morning function rather than immediately receiving a load it has not prepared for. Upon waking, 300 milliliters of plain warm water. This is the hepatic perfusion restoration step. The liver receives 25% of cardiac output, and after 8 hours of overnight blood pressure reduction, hepatic blood flow is at its daily low. Warm water before coffee begins restoring hepatic perfusion before caffeine's vasoconstrictive effect further reduces it. 15 minutes later, 1 cup of warm dandelion root tea. As I described in the Yellow Eyes video, dandelion root specifically stimulates bile production and bile flow, activating the liver's primary excretion pathway for bilirubin, cholesterol metabolites, and lipid compounds. Morning bile flow activation before breakfast means the bile ducts are clear and active before the first meal's lipid processing demand arrives, instead of sluggish and concentrated from overnight bile stasis. 30 minutes after the dandelion tea, a small handful of raw walnuts, approximately 20 grams, eaten slowly before breakfast. Walnuts provide arginine for nitric oxide synthesis, supporting the hepatic blood flow that every liver function depends on, and glutathione precursors, including the amino acids cysteine and glutamine that the liver uses to synthesize its primary intracellular antioxidant. The liver's glutathione production is both the primary determinant of its detoxification capacity and the primary defense of hepatocytes against the oxidative damage that accelerates fatty liver progression. This 3-step morning sequence, warm water, dandelion root tea, walnuts, takes 30 minutes and requires no equipment beyond a kettle and a packet of walnuts. It is the morning liver activation that replaces whatever the morning currently begins with that is not doing this. The 7 foods that directly address all 5 mechanisms driving the 5 I signs. Cooked brassica vegetables, broccoli, Brussels sprouts, cabbage, kale, 5 times per week, lightly steamed. The sulforaphane in these vegetables induces the NRF2 pathway, upregulating the UDP glucuronidyltransferase enzymes responsible for bilirubin conjugation, the cytochrome P450 enzymes responsible for phase 1 detoxification, and the glutathione S-transferase enzymes responsible for phase 2 conjugation. This is the most comprehensive hepatic enzyme induction available from any single food category. 5 servings per week, lightly steamed, not boiled to death. Sulforaphane formation requires the enzyme myrosinase, which is destroyed by overcooking. Steam for 5 to 7 minutes maximum. Artichokes 2 to 3 times per week, any preparation. Artichokes contain cynarin and silymarin precursors that specifically stimulate hepatic bile acid production and support hepatocyte regeneration. Multiple clinical studies have shown measurable reductions in liver enzymes, triglycerides, and total cholesterol following regular artichoke consumption in adults with fatty liver. The mechanism is specifically hepatoprotective. Artichoke compounds support the liver cell membrane integrity that is compromised in fatty liver, reducing the leakage of liver enzymes into the blood that produces the enzyme elevations on liver panels. 2 to 3 servings per week. Tinned artichoke hearts in water are as effective as fresh. The active compounds survive the preservation process. Turmeric with black pepper and fat daily, every day, without exception. The curcumin in turmeric reduces the NF-κB inflammatory pathway that drives hepatic stellate cell activation, the mechanism by which fatty liver progresses to fibrosis. Curcumin also specifically reduces lipid accumulation in hepatocytes, supporting the reversal of the fatty infiltration visible on ultrasound. 1 teaspoon of turmeric, a pinch of black pepper, a teaspoon of olive oil, or consumed with a fat-containing food every day. The fat and pepper are not optional. Without them, curcumin bioavailability is negligible. Eggs, 2 whole eggs daily, soft-cooked yolks. The choline in egg yolks is required for the liver to package and export fat from hepatocytes, the mechanism of VLDL synthesis that prevents fat accumulation in the liver cells. A liver sufficient in choline exports fat efficiently. A liver deficient in choline accumulates it, producing the hepatic steatosis that drives every sign we are discussing. 2 egg yolks per day provides the choline that the liver needs to perform the fat export function that prevents fatty liver progression. This is the most direct dietary intervention for the fatty liver mechanism driving signs 2, 3, and 4. Oily fish, sardines, mackerel, herring 3 times per week. EPA and DHA reduce hepatic triglyceride production, reduce the inflammatory cytokines activating hepatic stellate cells, and specifically reduce the lipid burden that is depositing in the eyelid tissue as xanthelasma and in the cornea as arcus senilis. The same serving of sardines addresses the vascular inflammation of Frank's sign and the hepatic lipid clearance impairment of eye signs 2 and 3 simultaneously, making oily fish the single most cross-targeted food in this channel's entire nutritional protocol. Beets, eat 3 times per week. Betaine from beetroot supports the methylation pathway that the liver uses to process homocysteine, the neurotoxic compound whose accumulation I described in the choline video. But more directly relevant here, beetroot's betalain pigments specifically protect hepatocytes from oxidative damage during the detoxification process and have been shown in liver cell research to reduce lipid peroxidation, the process by which accumulated liver fat becomes oxidatively damaged and drives the inflammatory cascade that accelerates fatty liver progression to more significant stages. Raw garlic, 2 crushed cloves daily, rested 10 minutes before use. The allicin that forms on crushing specifically activates the liver's phase 2 detoxification enzymes and directly reduces hepatic lipid accumulation through the AMPK pathway, the same cellular energy sensing pathway activated by exercise and by the diabetes drug metformin. Garlic is effectively providing a mild AMPK activation signal to the liver hepatocytes every day, supporting the cellular machinery that prevents fat accumulation and promotes the lipid export that healthy liver function requires. 3 things to stop doing that are directly accelerating all 5 liver eye signs simultaneously. Stop all alcohol entirely for a minimum of 12 weeks. I understand this is the most resistive recommendation for many people. I am not making it for moralistic reasons. I am making it because alcohol is metabolized exclusively in the liver by the same enzyme systems, alcohol dehydrogenase and acetaldehyde dehydrogenase, that compete with every other hepatic function for processing capacity. Every gram of alcohol processed by the liver is processed instead of the bilirubin, the lipid metabolites, the detoxification substrates, and the albumin synthesis precursors that should be the liver's primary work. For a liver already showing its strain in the mirror, in the yellowing of the sclera, the eyelid deposits, the corneal arc, the vessel prominence, the persistent morning puffiness, There is no safe minimal alcohol level, not one glass. 12 weeks of complete elimination, reassess the mirror, then make an informed decision about whether to reintroduce. Stop all fructose in liquid form, as I described in the yellow eyes video and the stomach fullness video. Morning orange juice, smoothies from whole fruit, any sweetened beverage, all of these deliver fructose directly to the liver for exclusive processing, competing with bilirubin conjugation and lipid clearance, contributing to the hepatic triglyceride production that drives fatty liver progression, and directly worsening every one of the 5 mechanisms producing the 5 I signs. Stop taking any supplement or over-the-counter medication, including those marketed as liver support, without checking whether its active compounds are metabolized by the cytochrome P450 system. A surprising number of herbal supplements, including kava, comfrey, green tea extract at high doses, and certain traditional Chinese herbal preparations, are hepatotoxic at the doses contained in commercial supplements. For a liver that is already showing strain in the mirror, adding hepatotoxic supplements marketed as support is precisely the wrong direction. Check every supplement with your pharmacist before continuing it. The mirror monitoring practice. Every morning in consistent light, in a consistent position, look at all 5 signs systematically. Scleral color, eyelid deposits, corneal arc, vessel prominence, periorbital puffiness and its duration. Take a monthly photograph of both eyes open in natural light at the same time of morning. Date every photograph. You are not looking for rapid change. The bilirubin deposited in scleral elastin clears slowly. The xanthelasma deposits reduce slowly as the hepatic lipid processing improves and the circulating lipid burden falls. The arcus senilis, once established, does not typically reverse, but its stability indicates that the process adding to it has been slowed. The vessel prominence reduces over weeks to months as portal venous pressure improves with reduced hepatic fat content. The periorbital puffiness is typically the earliest sign to show improvement, within 4 to 6 weeks of the full protocol, because albumin synthesis responds relatively quickly to improved hepatocyte nutrition. Direction over time is the measure. Each sign improving, stabilizing, or worsening tells you something specific about the liver mechanism it reflects. The mirror gives you a monthly liver function assessment that no annual blood panel provides. 5 steps. Starting tonight and tomorrow morning. Tonight, look at all 5 signs in your best available light. Photograph both eyes open from directly in front. Date the photograph. This is your baseline. Everything the protocol produces from this point forward will be measured against what you are looking at right now. Tonight, if you have any form of alcohol in your home, make the decision about the 12-week elimination before you go to sleep. Not tomorrow, tonight. The decision made tonight is the first liver protection that begins before the morning protocol. Tonight, place the kettle somewhere you will use it first thing. Place the dandelion root tea beside it. Place the walnuts in a small dish ready to be reached before breakfast. These 3 items, kettle, tea, walnuts, constitute the morning activation sequence that your liver has been waiting for every morning for years. Tomorrow morning, warm water, dandelion root tea 15 minutes later, 20 grams of walnuts 30 minutes after that in that sequence. Before any food, before coffee. This is the morning liver protocol. Every day from tomorrow. This week, buy broccoli, artichoke hearts, sardines, beetroot, and turmeric. These 5 items address every liver mechanism, producing every one of the 5 eye signs you looked at in the mirror at the beginning of this video. They are available at every grocery store. They cost less than any supplement currently marketed for liver health. And unlike most supplements, their mechanisms are not only plausible, they are documented, specific, and targeted at exactly the pathways that are failing. How old are you? Write your age in the comments right now. I ask because the rate of hepatic blood flow decline, the typical fatty liver accumulation pattern, the degree of bilirubin conjugation, enzyme suppression from inflammaging, and the albumin synthetic capacity reduction, all of it progresses differently between 62 and 76. Your age tells me what this channel needs to address with the greatest urgency and depth. And tell me this, how many of the 5 signs did you see when you looked at your eyes at the beginning of this video? Write the number in the comments. 1, 2, 3, 4, 5. I want to know how many people in this audience have been carrying multiple simultaneous liver signals in their eyes every single morning, explained individually as aging, as tiredness, as skin changes, as eye changes. while the single organ responsible for all of them has been waiting for a conversation that no appointment has yet initiated. If someone you love has eyes that are not quite the white they used to be, has yellowish deposits at the corners of the eyelids they have been told are benign, has a gray ring around the iris they have been told is normal aging, has persistent morning puffiness that does not resolve through the day, send them this video. Their eyes are not aging. Their eyes are reporting. They have been reporting the same thing in 5 different languages from the same source every single morning in every bathroom mirror they have ever stood in front of since before anyone thought to look carefully enough to read what was being written there. The liver does not announce itself. It does not make appointments. It does not send letters. It writes on the surface of the eyes, quietly, gradually, faithfully, in the language of bilirubin and lipid and albumin and portal pressure, and waits for someone to learn to read. Look at your eyes again right now, in better light this time, with the knowledge that what you are looking at is not how your eyes look after 60 years of living. It is how your liver has been feeling for longer than either of you realized. And now, finally, you know what to do about it.